Good afternoon. My name is Adrian Dix. I'm BC's Minister of Health. To my right is Dr. Bonnie Henry, BC's Provincial Health Officer. This is our briefing and session on modeling and going forward today. Just to give you a sense of what the week's going to be like, tomorrow Dr. Henry and I will be giving a briefing here at 3 o'clock, just a regular daily briefing. On Wednesday at the same time, Dr. Henry and I will be joining the Premier to give a briefing on the going forward strategy. And so that's your sense of what happens in the next few days. We're honored to be here, Dr. Henry and I, on the territories of the Lekwungen-speaking people, the Songhees and the Esquimalt First Nations. We wanted to thank, as they're here with us every day, our ASL interpreters, Nigel Howard, the co-interpreter Sarah McFadden, others involved, Scott Jeffrey, Jennifer Ferris, Nicole Pedno, Tyler Churchman, Jessica Seigers, Susie, Piper, and Christy were the managers that booked them. Nigel and I have a common history. His dad was my soccer coach for 10 years, and his brother Mark was a friend of mine, and I think we went about 35 years not meeting each other, and now he's either here or here. I'm not sure where he is, but we're really appreciative of their extraordinary work. I think all of us, just speaking for myself, have learned a lot from Nigel and his team over the last few months, and we're so appreciative of all that they do. Today, we'll be giving a normal daily briefing. Dr. Henry will be doing that first, and then taking you through a session on modeling, telling you a little about where we've been and perhaps where we're going. And so with that, I'm honored to introduce Dr. Bonnie Henry.
Thank you very much, and good afternoon. To start with, we'll update you on the number of new cases that we've had in BC since our last report on Saturday. So that is for two periods, between May 2nd and May 3rd, and then May 3rd to today. So our first period from Saturday to Sunday, we had 34 new cases diagnosed here in British Columbia, bringing the total that day to 2,205. And then over the last 24 hours, we've had an additional 19 people test positive for COVID-19 here in BC. So that's 53 new cases since Saturday, bringing our total to 2,224. Of those, 845 people are in Vancouver Coastal Health, 1,027 are in Fraser Health Region, 124 people were in Vancouver Island Health, 177 in Interior Health, and 51 people in the Northern Health Region. We currently have 23 active outbreaks in long-term care, assisted living, and a couple of acute care units. There are no new outbreaks in those areas. Actually, there's no new outbreaks to report today. We have had additional cases, 13 cases in long-term care assisted living or the acute facilities that have been affected, bringing our total in those areas to 266 residents and 168 staff. In our community outbreaks, I will update you on where we are with those. As you're aware, we have 3 outbreaks that have been declared in poultry processing. We now have 7 positive cases in the Fraser Valley specialty poultry, 54 people who've tested positive from Superior Poultry, and 35 from United Poultry. And I apologize, I had the numbers incorrect on Saturday. In addition, we're up to 134 people associated with the Mission Federal Correctional Facility, including 121 inmates and 13 staff who've been affected. We also, as I mentioned on Saturday, have continued to have people associated with the Curl Lake plant in Alberta. We have 15 people who directly from that plant who have tested positive in BC, and we also have additional family members. And this is one of the reasons we have been so concerned, and we have asked anybody who's returning from working at the Curl Lake plant while the outbreak continues there, and we do know that it is continued, and if they have no more cases, it'll be near the end of May that the outbreak will be declared over. And I know they've put in a great deal of the important outbreak response measures in the facility there in Curl Lake, and that is really important to help protect everybody who is on site there. But when people are coming back from an outbreak, we do here in BC require people to self-isolate whilst they're here. And that is because we know that people who have been in an outbreak situation are at higher risk of developing this illness during the incubation period. And so until the outbreak is over in Curl Lake, we do have that requirement for people who have returned here. And we also ask their family members to be careful and to monitor themselves for symptoms. We have had occasion where a family member of somebody who's worked in Curl Lake who's come back and not recognized that they've had a mild illness, have passed it on to a close contact, and that close contact was a healthcare worker. So we need to be very vigilant right now that we're monitoring ourselves and being very careful where we know that there's risk of transmission of this illness. Currently, we have 77 people here in BC who are in hospital, and of those, 20 are currently in critical care. Unfortunately, we've had another 3 deaths related to COVID-19, all of them in long-term care here in the province, bringing the total number of people who've died to 117. And as always, we are thinking every day of the families and the care providers for these and the communities of these people. We now have 1,417 people who have fully recovered. So what I'm going to do now is walk us through some of the information that we've had on who's been affected by COVID-19 here in BC. Some of it is questions that have come in through the last little while, and what we call the epidemiology, the who, what, and where. So you will have a better understanding of how this has affected us and our communities here in British Columbia. So what we've entitled this is the epidemiology, how the virus has affected people in BC, and there's several different aspects of this that I will run through with you. This is something that you've seen before. This is what we call our epidemic curve. So this is the number of new cases per day. And how this is plotted is by the date of onset of their illness. So this is after the public health investigation where we talk to people about when and where they may have been exposed and when their symptoms start. And as you can see, since we put our control measures in, that's those dotted lines, in March, we have had a dramatic and sustained decrease in numbers of new cases. We have had, of course, some of the clusters that you're familiar with the outbreaks that we've seen. This also gives us a sense of where people have acquired their illness. The yellow bars are the ones where we are still doing the investigation. But as you can see, most of them is known from links to local acquisition. So that is our community spread. And that is what we're watching very carefully in the coming weeks and months. As we have said as well, there's every area of BC has been affected, and every community has been affected, whether they've had lab-confirmed cases or whether we've had people who've returned from travel, who've been involved or connected to outbreaks and clusters in other countries, on cruise ships or around the world, or here in BC. Every community in our province has had some brush with COVID-19. This is a group of slides, a group of figures that paint the picture of who is being most affected by COVID-19 in our province. And what it shows is men and women in the different age groups. And in the one slide, and let's see if I have a pointer here. There. Oh, I don't. Okay. At the top right, no, I guess it's top. The top right, I guess. Yeah, the one that says case counts %. What you can see is that most of the people who have been affected, so that's people who've tested positive for COVID-19, most of them have been between the ages of 30 and 60. And there's been more women than men affected. So the lighter pink bars are women and the darker pink bars are males. So what we can see from that is that most of the people who have been sick with this illness are people between the ages of 30 and 60. If we go over to the one directly below, the one that says case counts, to the percentage of hospitalizations, what we see is a shift to the older age groups. So those people who have severe enough illness to need to be in hospital tend to be older, mostly people in their 70s, 80s, and even 90s. And if we look at the difference in the pink bars, as we get older, we start to see that men more than women have more severe illness that require them to be hospitalized. If we go to the top right or top left here on the screen, these are the numbers of people and the percentage of males and females who are admitted to ICU. So those are people who need more advanced care. Many of them require ventilatory care. And again, what we can see is there's a shift to older age group again. So this is just breaking down some of the information that we presented 2 weeks ago that shows that most of the people in ICU are in their 60s and 70s. And again, more men than women required that critical care. I will also point out, though, that younger people are not immune, and we are seeing people as young as 20s and 30s who require hospitalization and also who've been in the intensive care unit. Finally, on the bottom slide here, we have the same information by the number of people who have died. And again, we can see there's very much a shift to the older age group. The majority of people who've died have been people in their 70s, 80s, and over 90. We also have seen that it's much more that half of men over age 90 have died, whereas it's less than 20% of women. So this is a phenomenon that we're seeing around the world, that men are more likely to have more severe illness, to require hospitalization, and to die from COVID-19. And we really don't understand why. There's a lot of work going into trying to understand that phenomenon. Next, this is some information about healthcare workers, and we've been asked that question, how many healthcare workers have been affected? And so this is all healthcare workers as of April 28th. And so what we're talking about is anybody who's one of the regulated health professions, so that includes dentists, dental assistants, for example, as well as nurses, physicians, physiotherapists, others, care workers in our healthcare system. So many of these people were affected at work, either from a colleague or from acquiring this from caring for patients with COVID-19. But it also includes people whose exposures may have been through travel themselves, through attendance at, for example, the dental conference that we know about, or from exposure to family members who may be positive for COVID-19. So what we can see is 21% of our total cases as of April 28th, or 428 people, were healthcare workers across the province. But thankfully, a very small proportion of them, only 8%, were hospitalized. 3% required intensive care. And unfortunately, we had one person who died. So this tells us that most of our healthcare workers, thankfully, were in the younger age group and were mostly younger and female and did very well and had milder illness. One of the other things that we've been looking at very carefully is what are the things, the risk factors that people have that make it more likely that they will end up with more severe illness. And this information that I've provided here, and we've got 2 slides that show it, is the information that we have complete records for. So it's not the entire group of people, the 2,000 and so people who have tested positive yet, because it takes some time before we know that people end up in hospital or their outcomes. But this is the complete data as of April 30th, and of those of the people that are presented here, 1,373 reported one or more of these additional risk factors that make it more likely that they'll have more severe disease. What we can see is that of all cases, being over the age of 50, about 56% of all cases, and this goes back to what I was saying, where it's mostly a younger age group, but of those admitted to hospital or into intensive care, 80% of those people were over age 50, and a very high proportion, 97% of people who died were over age 50, and we know that the majority of them were in their 70s or 80s. The second line talks about male versus female, and this is similar to the information I just presented, where about 44% of all of our cases are male, but they're 2/3 of our cases who end up in hospital or intensive care were male, and almost 3/4 of our deaths were in men. Finally, we look at chronic conditions, which means things like diabetes or underlying heart disease or lung disease that make you more likely to have severe illness. And we can see that about a third, a little over a third, almost 37% of all cases, everybody who was diagnosed, had at least one chronic condition. But you were much more likely to end up in hospital. About 2/3 of people who ended up in hospital had at least one chronic condition, and 3/4 again of people who required ICU care, and 83% of people who died had underlying illness as well as a risk factor. Again, this is the same information, just presented so that you can see the progression of these risk factors and the impact on the severity of illness. One of the other outcomes that we are looking at is how well people do once they have been in critical care. So overall, as of the time that we put these numbers together, up till April 29th, we had 199 individuals who required critical care. And of those, 28 people died. So that's 14%. Which is, of course, a very high number. And we can see from what we just presented that these are mainly men over the age of 50 who've had underlying conditions. On a positive note, 110 of the 199 people have been released from hospital and have recovered, and a number in between are still in the recovery. The next slide just presents a graphic of the number of people in ICU per day, per health authority, so you can get an understanding of how it's affected the different geographical areas. As we can see, most of the people requiring critical care have been in Fraser Health and Vancouver Coastal, and as we know in our pandemic, that's where the majority of people who have been affected have been. So last week we talked a little bit about looking at excess deaths, and there was a modeling study done in Ontario that considered the impact of the pandemic on the population. And I reported that this is a measure that we look at here in BC on an ongoing basis. And we have, on average, all-cause mortality is a very stable measure in our community. And on most days of the year, about 115 people die in British Columbia from a whole variety of causes, whether it's old age or motor vehicle crashes, overdoses, the other impacts that we have in our community. And we have been following the impact of COVID-19 on that measure over time. This is something that we have been doing for a number of years through the BC CDC. For example, when we had the forest fires of 2017 and the summers of 2018, we had very poor air quality for a number of weeks. And we saw the mortality, the all-cause mortality, in excess of normal for several weeks afterwards. This graph gives you some indication of what we've seen in the last few months with the impact of COVID-19. We have had about 170 excess deaths since March, and the vast majority of them, at least 111 that we know of so far, have been attributed to COVID-19. So that does give us a measure that this outbreak has had a population effect. What we don't know is what else is causing these excess deaths during that period of time. And what we get is more detailed information from the vital statistics, from the death certificates over time, and we will be able to look back. We get the ones for March at the end of this month, and then we'll be able to look back and find out what were the other contributing factors to the excess deaths that we've been seeing here. And we think it's very likely some of them will be indirectly related to COVID-19. There may also be causes, for example, we know that people were not going to the emergency department because of concerns about COVID-19, and it may be that there was excess deaths that were recorded from that. So we will, once we have that information, be able to provide it to you as well. So the case rates, these are slides that are just an update of ones that you've seen before. This shows our rates per million population in British Columbia compared to the rest of Canada and to a number of other countries. And as you can see, this is the work that we have all been doing over the past few weeks in what we've called bending the curve and now flattening it. In addition, this is an update of the death rates by countries here in BC, the rest of Canada, and a number of other countries, showing again that we have leveled off, and of course that it reflects the numbers of deaths that we've had, unfortunately, in long-term care homes in our elderly. All right, next I'm going to turn it over to Minister Dix, and we're going to give you a little bit of an update on some of our critical care.
Thank you very much, Dr. Henry. And what we're going to look at here is our provincial bed capacity in critical care. And you see it up here now. We have reduced some of our surge capacity since the last time we updated you, from 951 to 704 critical care beds. Nonetheless, we currently have a critical care bed occupancy rate of about 44%, so 390 total vacant critical care beds. You see in the two categories there that we have 30 people as of this graph's information, which was May 1st, 30 people in critical care for COVID-19. Dr. Henry's just updated that to 20 as of today, May the 4th. So that's what's in critical care. And then there's 284 people who are in critical care for non-COVID-19 cases. So to move on to ventilator capacity, again, as you can tell from when we started or where we started in March, we've significantly increased our ventilator capacity, and you see that in addition to that, we have portable ventilators and an intention to increase the ventilator capacity of the province in the coming months to deal with the potential for future surges. It should also be pointed out that the Premier a couple of weeks ago announced our plan to add ambulance and transportation capacity to bring people, especially from rural and remote areas, closer to critical care. And just if you go on from there, this is the use of mechanical ventilators in critical care as of now. So you see on the top row that as of April the 30th, there were 112 people on mechanical ventilation at that time, 17 of them at that time, so it's a subset of those in critical care were on mechanical ventilators on April the 30th. That total as of today, the updated total is 9 for COVID-19, so you see that we are well within our capacity for mechanical ventilators. So just to be very brief about this is an updating of what we presented to you a few 2 weeks ago, that we've remained ready, obviously, for critical care patients, including those with COVID-19, that the number of patients with COVID-19 has slowly decreased over time, as we've seen, reflecting also the reduction in hospitalization. We regularly report on the number of vacant beds overall in the healthcare system, which today will be 4,075. What that has permitted us to do is to prepare and be prepared for COVID-19 surges in the healthcare system, and also, most importantly, protect and support healthcare workers, be they doctors, be they nurses, be they healthcare workers or health sciences professionals. And also, we have additional adult-capable critical care ventilators have come into the inventory, as have additional adult portable ventilators, which can easily be moved between sites or with patients. Additional adult ventilators are expected to arrive in the weeks and months to follow, and we will keep you updated on those numbers. And I'm going to return it back to Dr. Henry.
Thank you. So for the next part, what we wanted to do was give you an update of where we were, who's been affected, and as you can see, it's had an impact, quite a dramatic impact on our entire population, differentially affecting those who are older, but also very much affecting younger people, and particularly younger people who have underlying illnesses. We also have a significant proportion of our cases who are healthcare workers. And this is what what we've accomplished here in BC has been able to protect everybody and ensure that they had the best chance at getting the care they needed. So where we need to move from here, here's where we are at the point where we have deflected our curve. We're coming down nicely. We have the measures in place that we know are working. And how can we use modeling and the work that we've been doing over the past months to understand where we need to go in the coming weeks? And so this is an update of the slide we presented a little over 2 weeks ago that gives you a sense of some of the modeling that we're using to inform our decisions. So what this shows is the ventilator capacity, the critical care patient census, so the number of people in critical care up until the end of April, that's the yellow bars. And then these lines give us a sense of what would happen should we let up the restrictions that we've put in place too soon, too quickly, or too much. And that is the work that we are now looking at to guide our way forward. So this is what we call the compartmental modeling that we've been doing, the dynamic modeling. It looks kind of weird, I guess, in 2D. But what it does is it takes into account what is exactly has happened in our community. It looks at the types and numbers of interactions that we have in our community. It looks at how that has affected our pandemic, and we've been tracking our cases, both in the cases in the community, as well as cases diagnosed in the community, as well as those in hospital and those in ICU. And this helps us understand where we fit. There were a number of different models that we were looking at, and this is the one with the best fit to what has happened to us. And it allows us to say, okay, these are the things that changed over time, and here's where we are now. What are the scenarios that we could see happening if we change some of the parameters going forward? So just to explain this a little bit more, the dark pink line in the middle is the smoothing or the average of what has happened in our pandemic over the past 2 months. And those lines with the dots are the actual case counts per day. As you can see, we had a dramatic increase in March. When we started to put in our measures, we were still seeing cases go up, and that's because we know the incubation period is 2 weeks. So when we first started to do our physical distancing and our staying at home and our closing up of a number of areas where we gathered and people working from home, all of those measures meant that we started to see a decrease in new cases after 2 weeks. We had a bit of a blip, as we know, a couple of weeks ago that was related to both opening up our testing so that we were testing more people again, but also the outbreaks that we've had in our community that we've recognized. And it really is a cautious tale. When we looked at the poultry industry, the poultry manufacturing, and recognized that there was transmission going there that was unrecognized, and that we needed to be sure to be able to safely open other places and to continue to provide those essential services, that we had the right things in place. So this is where we are now with the distancing that we've done, and I showed you before that we have our physical distancing and the staying and working from home and schooling from home has brought us to about 30% of our usual contacts in the community. And the next series of slides gives us some sense of what might happen once we start to loosen those restrictions, whether we have more contacts and what type of contacts they are. So there's 2 ways that we can look at this. One is what can happen if we have more unprotected contacts with more people, and the second is how can we manage that by having increased numbers of contacts but in a safe way. So the first graph tells us if we increase our contacts from where we are now to about 40%, we would expect that our new cases will continue to be relatively low over the coming weeks and months. And our hospitalizations would similarly stay relatively low, because we know only a portion of people who get sick with this virus need to be in hospital. The second in the middle, second set of graphs tell us what could happen if we increase our number of contacts by from basically double what we are now, from 30% to about 60%. And again, that shows us that we might have increased numbers of cases and some hospitalizations over time in the coming weeks, but they would be manageable. We would be able to continue to have the surge in our community to be able to manage that. And there are things that we can do that make these types of contacts, the increased numbers of contacts, safer for people as well. Finally, on the 80%, that means if we go back to December, where we were having lots of gatherings, where people met, where this virus has the opportunity to take off quite rapidly, we could expect to see just that the more potential for transmission between people means that the virus will be able to increase exponentially, and we might be in a situation that we've seen in other places around the world where we have a rapidly increasing outbreak, rapidly increased number of people who need hospitalization. So our challenge and our work together is to find that sweet spot, somewhere around, increasing our contacts by at least half or twice as many as we have now, but without allowing those opportunities for rapidly exponential growth of the virus in our communities. So that is what we are basing our goals on for going forward. We must find that right balance to protect lives by suppressing transmission to the lowest rate possible, particularly to try and protect those who are more likely to have severe illness, to end up in hospital, or to die from this disease. We need to ensure that our health system continues to have the capacity to offer the care that we need, both for COVID-19, but also for all of those other health issues that we have in BC. We need to meet, of course, the physical and mental health challenges that come with the social restrictions that we've had in the last few months. And that is important as well. We know that our mental health, our economic health, affects our overall health in our population as well. We need to rebuild our resilient economy and provide supports for people so they can safely return to work. And we need to strengthen our social fabric. It is important for us to have connections, both with our households and our families and our more extended families. But we need to do that now in a controlled way, in a managed way, and in a safe way. One of the models that we're using, or frameworks that we're using to help underpin our way forward, is what we call the hierarchy of controls. And this comes from the infection prevention and control world in healthcare and other worlds, and other realms as well. What this is, it looks at what are the most effective ways of preventing transmission of this virus. There are things that we know work and work well. Physical distancing, it has made a difference. It has allowed us to put the brakes on COVID-19, but we haven't stopped the car, and it's very unlikely that we're going to be able to, at least in the coming months. There's so much that we actually don't yet know about this virus. And this is not just us here in BC or in Canada, it's around the world. And we're looking at this in great detail. We're watching what's happening in other countries. But until we have a vaccine, we know it's going to be here in some way. And our job, our role, our goals in the next months is to make sure that we learn how to live with this virus in a safe way that protects people. This year, maybe that with so much unknown, is going to be unusual. We don't know yet whether we're going to have a resurgence of respiratory illness when influenza season and respiratory virus season starts again in the fall. That is something we need to plan for, we need to prepare for, and we need to monitor for starting now. The other things that we need to think about is engineering control. So those are things like the physical barriers that we see, the plexiglass that's put up, that helps us have, when you can't keep your distance, making sure that you can have that contact with somebody in a safe way. And then we talk about things like administrative control. So that would be reducing the number of people that are in a building, putting those markers on the floor so that you follow one-way traffic instead of going back and forth and crossing over. And things, incredibly important things like making sure we have policies that mean people who have illness do not go to work and are not penalized for that and do not go to school. And then finally, the least effective measures that we have that we do need to use in some situations are things like personal protective equipment. And those are the things that we need to think about in our communities in the coming months. You know, what is the role for things like wearing non-medical masks in certain situations? So this is it. For our key principles for going forward are staying informed. And we are committed to providing you with the best information that we can, following the advice that we have. Practicing good hygiene, so the hand hygiene, the avoiding touching our face, the coughing into our sleeve, covering our cough, disinfecting frequently touch surfaces, those are all things that are needed and need to stay the same. Staying at home and away from others if you're feeling ill, that has to be our new normal forever. But really important in the coming days and months is how we make sure that this can happen in all of our lives and in all of our businesses, in all of our recreation and schooling, in every setting that we have. We recognize that this social interaction and connecting with close family and friends is important for all of us. It's critical for all of us. But to safely increase our interactions, there are a few important things we need to remember. First, the more people we interact with, the higher the likelihood that we'll be exposed to somebody who might be carrying COVID-19. Second, we need to think about who in our household may be at higher risk and need more protection. And that could be somebody who has underlying illness, somebody who's elder, somebody who's going through cancer treatments. And if we have a family member who's at high risk of severe illness, we need to consider the less interaction we have with others outside of our family. And reconnecting with even one additional person outside of our family or beyond our household or our bubble, our pandemic bubble, is a bigger connection than we may realize. One additional ring can make for a much bigger tree if we think about rings in a tree. When you invite one person outside of your immediate household bubble into your home, you're also inviting all of the people in their bubble, the people that they've had contact with. And that includes people from their work, from their home, and others that they've had close contact with. So these physical distancing and how we manage those in the coming months is going to be really important. We're going to be working on increasing our environmental cleaning, considering, as I mentioned, the use of non-medical masks. And of course, we need to consider as well our non-essential travel and how we're going to manage that through the summer months. So this is, I believe, the end of our beginning of this pandemic. We do not yet know what's going to happen, but we know that we have some room to increase our social connections, to increase our work, to increase our school and daycare and childcare. But as we start this new phase, we need to keep those principles in mind. They are the playbook for all of us to follow. And the Premier, as Minister mentioned, will be speaking this week to how government will be moving forward using these principles and a plan. What you can be doing now is use these principles we've shared today and think about how they affect you in your personal go-forward plan. Until we have all of the pieces in place, though, it's very important that we continue to do what we do right now because we know it's working and it's saving lives in our families and our communities. We need to continue to be measured and thoughtful on the circumstances based on what we are seeing with our pandemic here in BC. We all want to keep our province safe and to create the opportunities to connect more and to get our businesses going. We also know that nobody wants to return to having a rising curve of new cases or tragic deaths. It is our curve, and we can continue to push it down and keep it there. It is in our hands, as long as we don't forget to wash them. So let's keep this going, and let's keep with what we have been doing so far, which is being kind to each other, being calm, and staying safe.
Thank you very much, Dr. Henry. And before I make a few concluding remarks, I wanted to start by extending my condolences and all of our condolences to the families of the three people who have passed away from COVID-19 in the last 48 hours. We grieve for the family that's lost a loved one. We grieve for the caregivers that took care of them. We grieve for the family, the friends of that person who have lost them. And we grieve because the virus separates us in this time from the families and friends sometimes we need to grieve with us and to console us. We acknowledge every life that COVID-19 takes from us, because when we do, we affirm the value of that individual and the value of all individuals, and we put that at the top of our interest every day when we deal with COVID-19. As you can see, and as we all know and as we all experience, COVID-19 has forced us to make some very difficult decisions to restrict many areas of our society and our economy. Steps we've never had to take in our lifetime. We've never had to take actions to restrict our interactions so much. We've never closed off from each other to this degree. It has been an unprecedented time. I believe as a province, all of us were thoughtful and careful in taking the actions we've taken, basing our decisions on science when we began to put guidelines and measures in place. And we must be thoughtful and careful, still basing our decisions on science when we start reopening our society and our economy. We must continue to stop the spread while balancing a new normal. Our next steps must be the right ones for BC, and you've seen from Dr. Henry what many of them are, or the guidance that is going to guide us in taking those actions. Today's modeling shows us what has happened when we all join the fight and join together across BC. We made a difference. We made a very big difference, a difference that's kept most of us healthy, that's kept our healthcare system sound, a difference that saved lives of our neighbors and our friends. By standing apart and working together, we changed our future for ourselves, for the ones we love, for the ones we don't know. When we presented modeling 2 weeks ago on April 17th, I said it gave us hope, and indeed it did. I think today's modeling does more than that. It demonstrates that each day, every day, being 100% committed to working together to fight COVID-19 matters. It matters to the youngest and healthiest of us, as we've seen, and to the oldest and most vulnerable of us. Today's modeling underlines how and why we're all in this together. Getting this to this point has required sacrifice from all of us. The costs have been significant, and no more so than in homes of the ones who have passed away. But also, of course, for children who've not been able to go to school, for people who've worked a lifetime to build businesses and seen them profoundly affected. The costs have been high, and higher for some. The modeling tells us that making social and economic sacrifice has kept us safe and can keep us safe. But we know that social and economic sacrifice come with consequences. Today's data also make clear that we can't throw open our doors and undo all the work we've done to stop the spread and to keep our healthcare system and our society strong. But our efforts have created windows of opportunities to strike the right balance to renew ourselves, our connections with one another, and our economy. We need to hold the right balance of suppressing COVID-19 transmission and offering quality care to COVID-19 and non-COVID-19 patients alike, and do all the other goals that we have for one another. This will be a different summer than any of us has ever known, but it can be a summer of renewal if we hold fast to the rules and guidelines Dr. Henry sets for us to reduce transmission, whether talking about industry sectors or our own behavior. That means, of course, not going to work sick. That means, of course, washing our hands as much as we ever have done in our lives and then washing them again. But it also means, and we've seen this in our own activities, myself this weekend, when we go out, we're out grocery shopping, doing essential errands. We've experienced effective measures to stop the spread and keep us safe. Engineering solutions, such as the plexiglass barriers we see at checkout. On our way into the grocery store, we experience administrative solutions. We wait until staff tells us to enter because they're making sure there are not too many of us inside. And in some sectors, personal protective equipment, PPE, is part of that too. particularly where social distance can't be maintained. And by now we know, near the top of any list of controls, that physical distancing is critical for all of us. Over time, right now, physical distance saves lives. For now, physical distance is our closest friend, whether we run a business, we're employees, children, whoever we are. Physical distance is a key part of our social and economic renewal. It's tempting to view these solutions as an impediment to that renewal, to that impediment to economic activity, as a hindrance to us. But in fact, of course, they enable us to continue on and to get involved and to be more involved with one another. Physical distancing and all the other measures we talked about is our friend in renewing BC. So yes, we have to continue to stay 100% committed, even if some of the advice will change and adjust. We have to continue to stay 100% all in. It allows us to make this summer our BC summer of renewal. La modélisation nous dit qu'en faisant des sacrifices sociaux et économiques, nous pouvons rester en sécurité. Mais nous savons que le sacrifice social et économique a des conséquences. De plus, les données d'aujourd'hui montrent clairement que nous ne pouvons pas ouvrir les portes et de faire tout le travail que nous avons fait pour arrêter la transmission et garder notre système de santé solide. Mais nos efforts ont créé des fenêtres d'opportunité pour trouver le bon équilibre afin que nous puissions nous ressourcer et renouveler nos relations avec les uns et les autres et notre économie. Ce sera un été différent que personne n'a jamais connu, mais cela peut être un état de renouvellement si nous respectons les règles et les directives du Dr Henry. Se laver les mains, tousser et tourner dans les manches, rester à la maison comme nous sommes malades et bien sûr maintenir la distance physique. Avec le temps, la distance physique sauve des vies. Pour l'instant, la distance physique est notre amie la plus proche. Elle permet notre renouvellement social et économique. Continuer à rester 100% engagé, continuer à se donner complètement à 100% nous permet de faire de cet été notre été de renouvellement en Colombie-Britannique. Thank you very much, and we're happy to take your questions.
Thank you. Reminder to everybody on the phone, please press star 1 to enter the queue. You are limited to one question. Please, I would ask that you also unmute your phones. You are not audible until we call your name. First question is from Keith Baldry, Global News.
Good afternoon, Dr. Henry. You say we could go from 30% to 60% and call that manageable. I'm just wondering how we could visualize that in terms of what we could do 60% that we're not doing now when it comes to social distancing and other of that hierarchical code that was outlined in the presentation.
Yeah, so that's sort of our wiggle room, if you will, from where we are now. So the things that we're thinking about, it means that we can have increased connections with people, or we can have safer connections with people. So when we're talking about retailers, for example, we have good examples of how that works in our grocery stores. We need to think about those types of models in other retail settings. So it's still having the online, the sort of mixture of online and in-store experience, if you will, reducing the numbers of people that can be in a store at a period of time, making sure that we have hand hygiene available for people. So those are the types of things we need to think about. How can we lift the restrictions on restaurants and pubs within that framework of understanding how we can have increased but safer interactions over time? Some of the things that will not be changing that in the near future are the orders, for example, on numbers of people who can congregate together. And right now that's at 50. And because we think that we are able to maintain effective physical distancing. So all those other parameters have to be in there too. So if you're somebody who's planning a wedding or an event this summer, for example, these are the things that we'll have to think about. Smaller is better. Outside is safer than inside. have ways where you can have people who are more vulnerable to severe illness participate, but not have the physical connections. No buffets, for example, because we know that those are opportunities for sharing of viruses. So these are all the sort of building blocks or principles that we'll be putting into place. And as I've mentioned over the last few weeks, what our thoughts are how do we apply those in the different settings that we're going to be faced with in the coming summer. So we can do Little League Baseball, for example, but it'll look different this summer. I think one of the other things that I think is important to recognize is I don't believe that we will be doing this type of restrictions forever. We still do not know a lot about this virus. In particular, we don't know how long immunity lasts. We don't know how to measure it very well. As we know, there's been challenges with the tests, the serologic tests for immunity. So those are all those things that we will know more about once we get through this summer. We'll also know more in the fall about whether we're going to see a natural upsurge in infections because of the respiratory season. So we really are in uncharted territory right now, and that's why it is so important for us to maintain these principles through this summer. This is going to be a unique summer for all of us, and we're going to have to work very hard in my world, in public health, to make sure that we continue to detect every single case in our community and are able to manage it, to find the contacts, to make sure that we're not allowing transmission and outbreaks and growth. So it's going to be a challenge for all of us, but I think we can do it. We've shown in BC that we know how to manage this outbreak, that we can take the measures we need. Now is our time to start thinking about how we're going to have this unique summer together.
Next question is from Lisa Eusda, News 1130.
Looking at the numbers that we're seeing, Dr. Henry and Minister Dix, it looks like we're near zero by Canada Day. Is this something people can look forward to? Like by Canada Day is when we're going to see that we can be at this 60%, this new normal? Or are we going to be seeing that before then? Or are we going to be seeing a big difference at all by the time we hit Canada Day?
Yeah, good question. I wish I knew. I have to say that, my birthday's close to Canada Day, so, I would love to see that. The thing that models tell us are the possibility of things that can happen. It's not a prediction. And we've seen, you see the one bump there a couple of weeks ago when we had a couple of outbreaks in the poultry plant in Mission. So it all depends. And that's why we have to be thoughtful and careful about how we do this. And we also need to make sure we have the testing and the contact tracing and everything that we do in public health to try and keep it down at that level. But yes, I am hopeful we will get to zero, and I would love to see it as soon as we can. We know now that there are very few cases that are arising in our communities that can't be linked to a known case or a known outbreak. That's really good news for me. We also know, however, that this virus can be smoldering around undetected for some time because younger people in particular can have very mild illness and it can be transmitted to others, even with mild illness. So it's hard to say, but it would be really nice to be able to go into the summer confident that the measures that we're taking are continuing to work and that we can enjoy the summer together.
Next question is from Tanya Fletcher, CBC.
Hi, Dr. Henry. Just following up on those first two questions, everyone wants to know about this 60% kind of sweet spot with normal interaction. You did mention in your first answer about building blocks of various activities, but how does that apply to what you've said about expanding our kind of personal or social circles? And secondly, you said just now that you'd like to see this as soon as we can, but can you clarify to people whether that means they can start doing so right now?
Yeah, so in answer to the last question, no, we're not there yet. We're still hovering. We still have outbreaks. We still have people who are out there who are incubating this disease. We still are having cases in our community. So we're not at that point yet, but we're at the point where we need to start thinking about how we're going to manage this. And we'll talk some more about details and timing on Wednesday. The challenge that we're going to have around social interactions is, we all want to go hug our friends and, make sure that we can see our grandparents and our grandkids. And these are the things that that we are going to have to be cautious about. And I've talked about this a little bit. You know, the more people we interact with, the higher the likelihood that somebody may have this illness in our community and may unintentionally spread it to us. So we still have to be very wary of those opportunities where this can happen to a lot of people at once. And we have good examples of that, unfortunately, from Canada and from other parts around the world. Newfoundland and Labrador, for example, where the vast majority of their cases were linked to somebody who was not that ill who attended a funeral. We've had incidences where a variety of people were infected, a large number of people were infected at a birthday party. So we have to be very careful through this summer, because we know we can't get rid of this virus entirely. They think they have in New Zealand, but we are not an island like New Zealand. We have essential travel that comes back and forth into British Columbia and out of British Columbia. So we aren't able to maintain all of our borders in the same way. And it's very unlikely that we're going to be able to get down to zero everywhere in our province or everywhere across the country in the coming weeks. So we need to be cautious about that. We need to think as well, if we're going back to our office environment, if our kids are going back to school, how do we make sure that they then don't have as much contact with people who might be in our family unit, who might be more vulnerable to more severe illness? We also have to be really, really careful about having, I wouldn't say like zero threshold for staying home if we're not feeling well. And we need to enable schools and businesses so that it's the expectation that we all have of each other and that we're not penalized for doing that. So that's kind of a roundabout way, but more details will come in the next few days.
Next question is from Binder Sudjan, CTV.
Hi, Dr. Henry. Just with regards to the excess deaths, you said that COVID could be indirectly related and then talked about people perhaps not going to ER. Are there other issues that may have affected that number as well?
Yeah, absolutely. So there's a number of things that we don't know yet. We look at this over time and have for a number of years. So there are weather events that have effects. We know there was flooding. We know that there was motor vehicle crashes. So it will depend. Yes, we have heard reports that people have let the chronic illnesses get to the point where they need hospital care. We, of course, are worried about people not having access to surgeries, some of the scheduled surgeries. For the most part, though, we are confident that any urgent or emergent surgeries were being carried out over this period of time. And I must say, it is because we have protected our healthcare system that we've enabled that. So what we do is we get the information from vital statistics on the causes of death, and it has the cause, the underlying cause, etc. So we'll be analyzing that in the coming weeks as we do. So we've just had the data for January and February, so the critical March period we'll be getting in the next coming weeks, and we'll be able to assess that more carefully.
Les Lane, Times columnist.
Oh, thanks, Doctor. Slide 3, the epidemic curve by way of bar graph. It shows the local acquisition. I guess that's community transmission. The shade of purple, it's you've got a number of cases that were known to be linked to COVID cases, and then the paler shade is community transmission of an unknown source, and that's, 40-50% of it by the looks of it. Is that kind of what you would expect in a situation like this, and are you comfortable with that number of cases where they couldn't identify the exact transmission route?
Yeah, that's a really important thing that we're watching. So you'll notice that the majority of those community transmission of unknown source happened during the peak of the outbreak period. So some of those are people that we're still investigating. So there's a trace back that we can do. But as you notice near the end of April, those go down quite a bit. And so that's what we're focusing on. Going forward, that is what we need to, if you notice at the beginning, there was very few of those. And then as we're coming near to the end of the first wave of this pandemic here in BC, they're going down again. And so that is our work in building up the public health capacity to be able to rapidly detect and assess anybody who is COVID positive and link them and do that contact tracing. So that's what we'll be focusing on, and that's the one measure that I will be watching very, very carefully in the coming weeks.
Next question is from Moira Witten at IE.
Hi, good afternoon, Dr. Henry. Thanks for this. I'm curious about how you're thinking of your reopening, or not reopening, but your, relaxing and changing of measures strategy. When we think about crisis or pandemic fatigue, when we talk about going up to 60% of normal contacts, are you worried that, you'll give an inch and the public will take a mile?
Yeah. You know what? I think we have seen that people are very concerned about this, and we have seen what's happened around the world, and people know what we need to do. It's hard, and it's been hard on us all collectively to be where we have. So we all collectively have a vested interest in doing the right thing. And, I've said it many times. I really honestly believe that if we give people the information about what you can do, this is why we're presenting this to you. You understand the impact. We know what we need to do. We know where the limits are, and we know that most people will do the right thing. And I'm convinced that that is the case here in BC.
Next question is from Jane Sack, North Shore News.
Hello, Dr. Henry. I am hoping that you can update us a little bit about some of the situation that's been going on in North Vancouver where the outbreak started. I'm hoping that you can shed a bit more light on the outbreak at Lionsgate Hospital, which I understand is still ongoing, and also perhaps on the Lynn Valley Care Center, which I understand is coming to the end of its outbreak, perhaps.
Yeah, so my understanding from Lynn Valley is absolutely that. We have not had new cases there for some time. As I mentioned before, we wait 2 incubation periods before we declare an outbreak over in that situation. So we are still holding our breath on Lynn Valley, but it looks like things are going well. The other part that I mentioned was that the residents in Lynn Valley, 32 of them who have recovered fully from COVID-19 are taking part in part of the validation of some of our serological tests with the Vancouver Coastal and the BC CDC, and so I'm very grateful to them for that, for us learning from their experience. I don't have a whole lot of details on the unit at Lionsgate. I know that there was unrecognized transmission in one of the units there, and that there have been continued to be a number of cases that have been identified over the last few days. But again, that they have put in outbreak response measures and an outbreak response team to try and control it. Lionsgate has been in an outbreak setting, and so they have had less people coming in through the hospital than other facilities in BC.
Next question is from Robin Rowe, Info News.
Hi, Dr. Henry. On slide 6, I think it is, slide 7, you talk about the additional risk factors. And I know you've touched on this before about what are the key chronic conditions that maybe have an effect. And I know you've talked before about why it's more likely that males are more harmed by this more. I don't know if you can elaborate any further. You have any new ideas on why men are more subject to getting very ill?
Yeah, it's interesting. We don't actually know a whole lot. So in terms of the chronic conditions that are included in that, diabetes, heart disease, underlying lung disease, cancer, particularly immunosuppressed, people who are immunosuppressed. So those are the main ones that we've been looking at. As to why men are more likely to have more severe illness or to need ICU care, that's something that people are asking around the world. There is some theory that it might have to do with the differences in our immune system between women and men. In particular, that women have their immune system is less likely to have that overwhelming response called the cytokine. I'm sorry, I'm just having a mental block here. Cytokine storm that can happen sometimes with a viral infection like COVID-19. None of these are proven yet. We do know that that one of the receptors that the virus binds to is called the angiotensin converting enzyme 2 or ACE2 receptor, and that we do have a lot of those on our heart muscle and in our blood vessels and also in our lungs. And it could be that males who have more of a propensity for heart disease might be more affected because they have more binding sites for the virus. But again, that's theoretical as well. So it's a lot of really interesting physiological things that we don't yet know. We know, for example, that this virus tends to cause blood clotting, so strokes, pulmonary embolus or blockages of the blood vessels in young people even, and we've seen that in a number of cases both here in Canada, but particularly in the US and in other parts around the world. So these are things that we're watching. I know our critical care docs have been exchanging information about this and are working with others around the world to try and understand it better.
So we have time for one more question today. For any reporters that didn't get to ask a question, there will be a statement released later this afternoon. For recommendations on protecting families and communities from COVID-19, visit bccdc.ca. For non-medical questions about the province's COVID-19 response, visit gov.bc.ca/COVID-19. And for a full listing of the Provincial Health Officer's orders, visit gov.bc.ca/PHO guidance. Last question is from Richard Zisman, Global News.
Thanks for taking my question. Dr. Henry, one of the things being looked at by the National Hockey League is this idea of hub cities. And do you see it as possible that Metro Vancouver could be a hub city where NHL personnel and players come to play in the city? Is it something you would ever approve? And do you have what possible issues do you have with that idea about Metro Vancouver playing home this year to complete the NHL season?
Yeah, so one of the groups that I've been part of for quite a long time is a WHO group that looks at mass gatherings, and we've been looking at how you can have this type of sporting event safely around the world. So obviously in Europe, one of their big issues is around the football season, the soccer seasons finishing, and there are ways that we can do it safely. So I think it's an interesting idea, and I think there are ways that we could look at having games being played, perhaps in BC. Hockey would be one that we could certainly look at. There would be parameters that we've talked about. So I would not see there being an in-ice audience, for example, but we could broadcast the games, and there's ways that players can take precautions to ensure that there's physical distancing. And, when we think of hockey, which I love, people are wearing face masks. So there's ways that players are protected when they're on the ice. So I absolutely think that these are the types of things that we need to think about, how we can do them safely during this summer.
That's all the time we have for today. Thank you.